All right. Good evening, everyone. My name is Dr. Vince Mariano, President and Chair of the Valley District Dental Society. Certainly, we are in unprecedented times, and I appreciate all of your efforts to come here this evening to help us get to the other side. When I say unprecedented times, I mean there will be a time, I can assure you, that together we will get to the other side, and we will be prepared and more comfortable to meet our patient needs and take care of what we do best, dental health for our patients and our friends. Making you, all of our members and our staffs, more comfortable is what we are here for all of us tonight. Um, our plan is to have a program with our guest speaker, Dr. Howard Pactovis, to help us go through how do we prepare for the reopening of our dental offices. I think it'll be enlightening and very informative for all of us. The program this evening is being sponsored by your dental society, the Valley District Dental Society, financially and with the time of effort of my great board and all of our members together. I feel that we have done so much in support of what we're attempting to do, educate our members through these tough times. As we move into the program, and before I introduce our co-hosts, I want to thank Teresa Hayes, Teresa from the Massachusetts Dental Society, who has been instrumental in helping us with the technology to do these programs, especially for so many of our members and staff. I want to thank our co-hosts and educational co-chairs, Dr. Ben Falk and Dr. Michael Cabin, for all of their efforts in helping organize the program and working with Dr. Pactovis this evening and getting this all ready. A little bit of housekeeping. Unfortunately, because of the demand for this program, we've had over 300 registrants. So a number of people today unfortunately called and indicated that they could not get into the program this evening. And we apologize, but that is the maximum that we can do at the Mass Dental Society. So that being said, the program is being recorded, and soon after the program, an email will be sent out to all of our members so that it will be recorded and on a live YouTube channel for the Valley District Dental Society. The program, although all of your mics will be closed, there will be a chat session, and I've asked Dr. Ben Falk, our co-host, to monitor that channel and to forward questions to Dr. Pactovis directly. With that, I want to introduce Dr. Mike Cabin and Dr. Ben Falk to move forward with the program. Thank you both again for your time and efforts, and I look forward to seeing everybody in the future. Mike, Ben?
Awesome. Yeah, awesome. Thanks, Dr. Mariano. We're just so happy to have everyone. I want to welcome all of you. This is our first ever education meeting that we're doing virtually with the Valley District. So it's really an exciting time. I was so pleased to see the overwhelming support for the course tonight. Right now, you can see at the bottom of your screen, we have 191 people joining us tonight. So it's just great. I looked at the list of attendees. We have doctors, assistants, hygienists, front desk team members, everyone's here. It's what I believe to be probably the most important and impactful education meeting that we've had, at least in my almost 12 years being here in the Valley. So thank you all for your support and for attending the meeting tonight. I want to take the time now to introduce our speaker. That's Dr. Pactovis. We're going to try to tonight go about an hour and a half or so. Dr. Pactovis will speak. We're going to ask you, as Dr. Mariano said, to submit your questions through the chat. Dr. Falk and I will be looking at the chat. So if you're comfortable posting your question for everyone to see, just post it up there. If you want to do it anonymously, you can just send it directly to Dr. Falk or to me, and we'll get that question out to Dr. Pactovis. We also had some questions that were submitted ahead of the meeting tonight. Dr. Pactovis is going to address those directly as we go through the program. So again, thank you so much. Let me now introduce Dr. Pactovis. He's been a respected figure in the dental field for over 35 years. He's a graduate of Tufts University School of Dental Medicine and Boston University School of Graduate Dentistry. For the last 20 years, Dr. Pactovis has focused exclusively on the safety and risk prevention area relative to dentistry. He's the founder of Dynamic Dental Safety, the Director of Education for the Dental Learning Network, and has presented education courses in more than 20 states. He's been a featured speaker at the Yankee Dental Congress, as well as other state and local dental meetings on the subject of dental office safety and infection control. So let me turn it over. Thank you, Dr. Pactovis, for joining us. Why don't you take it away? Just unmute yourself to do it.
Here we go. I got it. And I can see the waiting room and everything. Can you all hear me? I think you can. I want to thank everyone, really everyone, for taking the time and effort to be here. It really is a challenging time. I do another presentation. I put a slide up. I call it Doing Dentistry in the Roaring 2020s. And it really is pretty much like that, because everything that we've learned, everything that we know is changing. And I've titled the presentation Pandemic Preparedness for the Dental Office. And I mean that for today and moving forward. And I think that that's the key. We've seen what can happen in a very, very short time that's thrown our world into upside down, and we're going to see it again. I hate to predict that, but we are going to see it again. I've always said to be prepared for a pandemic when I do my presentations, and I am sorry that I present as a little red on the screen there. I can never seem to figure out how to get myself looking better. I do not have a temperature. I was in 4 different offices today and had my temperature taken in each one of them, as you will do in yours. But I thought I'd go into a little background before. First of all, welcome you all. This is my email address. Please don't hesitate ever to contact me. Any questions? It's really, really important, whether it's tonight or whether it's moving forward. And that's my direct cell phone number as well. I don't hesitate to give it out to any dentist, any assistant, any hygienist. Why? Because it's so important to be able to reach out and get what I consider quality information. Right now, we're dealing with a lot of fiction. We're dealing with a lot of fact. It's hard to differentiate the fact from the fiction. So I start out by saying what's now and what's next. What's next, hopefully, is entering into that new era of dental practice. So I say it is putting the pieces together, doing all of this stuff, infection control, major, major stuff that we're dealing with, preventing the risk, and that's what we all have to be aware of. HIPAA is going to be paramount. Why? Because we're collecting a lot of data about our patients and visitors that we never did before, whether it be temperatures, whether it be information about where they were in the last 14 days. These people right here, our Board of Registration, is going to be changing their rules. We know that. We don't know how they're going to change them. So much of what I tell you tonight will be conjecture. We're trying to fly the airplane and build it at the same time. It's a very frustrating time for us, but the safety in the office is essential. You're getting continuing education for this, and this is where everything started with OSHA. So moving along, I say what we really need to be aware of, and this is the key thing in every office from today onward, is enhanced protection. And I say, what is it? Do I need it? How can I do it? And those are the key things. So I define it at the beginning. I say to enhance, it's to intensify, increase, further improve the quality. That's what we've always done in dentistry, but now we're going to further improve it. Do I really need it? Well, I believe that we do, because we're going to review a lot of this stuff today. Federal regulations, state regulations, our staff. I was just on with an office down in Connecticut, preparing them for next week when they're entering into the patient treatment realm again. Staff had so many questions. You all will as well. I welcome them. I encourage them. Our patients, not only are they going to have questions, but they're going to really quiz us. They're going to put us under the microscope. And visitors as well may be frightened to come in the office. Do we want them in the office? Is the office going to be designed the same way as it was? How do we do enhanced protection? Very simple. We have to assess what we have. Every one of us has to be very critical and assess each of our offices from the physical standpoint, from the infection control standpoint, from the staff standpoint, from the patient flow standpoint. And then we've got to implement new things. This is a daunting task. very overwhelming. How do you implement them? Well, I'll show you that in a second. And then you've got to maintain what you have. Not only maintain it, but increase it. I say one of the benefits from COVID-19 and the stoppage of our patient treatment and the cleaning out of our reception areas is I've seen a lot of the National Geographics from the 1950s disappear in the trash. Okay, with some of the older offices, that's what they had all the time. Federal level, all of these things. You've heard of OSHA, CDC incessantly on the news, NIOSH, National Institutes of Occupational Safety and Health, work hand in hand with these, many more. We deal with all these things. The basic thing that we have to do is document. In addition to improving our offices, we've got to show the documentation and more for our protection. With these things, infection control is going to be all changed. This one is new. Many of us have never had to deal with airborne transmitted diseases. This is the key. This is what the COVID-19 is. That's the unseen. That's what we're dealing with, which will lead to enhanced cleaning and disinfection aspects, increased sterilization. Vaccination is going to change. What do I mean by that? Not the physical procedure of vaccination, but the requirements. Up until this point, we've been required to offer the hepatitis B vaccine to our employees. Pretty soon, much more likely we'll have to offer the COVID-19 vaccine when we get it, maybe the flu vaccines or shots, different things like that. So be aware, be on the lookout. Once we enter the practice again, much more will be required. We're going to have to update. We're going to have all new working manuals, the new standards that will be out there, add important information, review the working protocols, observe the working behaviors. That's a key thing. We each have to help each other out in the workplace. I know everyone's interested in the nitty-gritty, and I'm going to get to that, the step-by-step process, the N95 respirator mask, and all the requirements with that. But you know what? Each one of us has behaviors. Some of them aren't positive, and we need to recommend to each other, we need to suggest to each other different ways to do things. We're going to be wearing more protective equipment. We have to deal with it properly, place it on properly, remove it properly, certain steps to do. And in addition, we have to make sure we don't contaminate it. That's where we involve our staff and the working behavior. So every single person, from the front desk individuals through the assisting, very important through the hygiene, and ultimately to the leader of the team would be the doctor. How do I do it? You're going to have to research everything. Many of us have been on probably interminable Zoom presentations like this one, heard different things, many conflicting. So you're going to have to research all of those. You're going to have to research the written materials. I will be more than happy if anybody wants, or I can provide it to any of the hosts here, one simple email with lots of different links that I feel are very valuable. In other words, distill the information, because then you have to review everything that you have currently in the office. Many of us have things dating back to the 1990s, the 2000s, 2010s. They're all going to have to be updated. Going to have to write specific things to your facility. If you're like Dr. Cabin, you may have multiple locations. Every one of them is going to be different. And then I suggest always try to reach out for expertise. That could be an attorney, it could be an accountant, it could be a business person, it could be someone like us. I put our name up there, a little self-serving, I apologize, but we'll be more than happy to help, no obligations. State level, these people right here, we hear from them, the Department of Public Health. They have lots of documents that relate not just to medicine, but to dentistry. The state's attorney generals, they're part of the legal and law enforcement aspect. You're gonna have to know all the state guidelines, adhere to the requirements. You're gonna have to implement everything that's new. So they're going to come out with certain requirements for us, which they will probably put out on the internet, some way, shape, or form. And then we've got to implement everything there. We can't say, oh, I didn't know about it. You didn't let me know. It's part and parcel of us as professionals, as business owners, what we have to do. And then we're going to have to get everybody together and train. And that's part of what we're going to begin today. So you'll see some of that. Why? To stay in full compliance. Staff security. We want our staff, everyone on this call that's either a dentist, an employee in one way, shape, or form. They could be a dentist, they could be a hygiene person, they could be an assistant. Everyone has to be secure. Otherwise, we can't do our job properly. There's so much information and so much insecurity in there that I'm going to try to give you ways to increase that today. The patient security, again, they've been watching the news the past couple of months, and ultimately protect everyone's license. State, you're going to spend hours. You could use a trusted source like us. That's one. There are many, many sources out there, but I encourage you, make sure that your source that you're using for your information is accurate. Even, I hate to say it, but even some of the agencies that we deal with, some of the societies and some of the associations are not really giving the entire picture. So I encourage you to question. I've sent many questions to the American Dental Association and received responses. Don't hesitate to reach out. You have to know everything, implement all the new items, and stay in full compliance. Ultimately, that protects you from transmission. So I'm going to skip by some of this because what I want to get to most important is this, the fact versus fictional aspects. We're seeing a ton of fictional material, okay? And that comes from the news media, it comes from newspapers, it comes from the internet. Some of it even comes from chat rooms. And that's what I want to warn people. Don't get caught up in the fictional aspect. If you think something is not real, then ask questions about it. Get verification, get documentation. There's this fear right now of airborne transmitted diseases. We're dealing with it. We're dealing with the COVID-19. You all know what it stands for. It stands for corona, CO, virus, VI, and disease, D. And then 19 is the year, 2019. So that's how they're going to label them all going forward. I say what I like to think of as COVID, meaning is the culture of values in dentistry. We have traditionally held the best values of any of the medical professions. We've traditionally had the safest offices of any of the medical professions. That includes the hospitals. You all have done the best infection control and will continue to and will enhance it to increase that trust in us, assure and reassure everyone for the patients of their safety, and prepare for the questions. They're going to come in, once we open our doors, they're going to come in with question upon question upon question. So that will lead to what we're really doing, which is really here evaluating our office. And I encourage you, because I start with this, and then I'll go into walking through a patient and different things like that. But the office assessment begins right here at the reception area. I want you all to take a very critical and clinical type look at a reception area. Make sure it represents what you want. Make sure the stuffed animals aren't there any longer. Make sure it is clean and neat. Make sure we can emphasize the social distancing there. In other words, don't have the chairs one on top of the other. Don't even invite the patient in until we are comfortable that they will be safe in the office and safe for us to have in the office. Clinical and operatory areas. Again, what I've seen in the past few weeks is I've seen a volume of material removed from the clinical area. In other words, many of us have just accumulated things in our operatories, whether it be the extraneous materials that we leave out on our countertops. I love everything to be clean and neat, very little visible. That allows for fewer questions. I'll give you an example. I was in an office about 2 weeks ago, beautiful office. And in the hygiene room, they had a bin that was full of small bottles of water that they would give out to a patient after they had their hygiene appointment. And I said to them, unfortunately, you're going to have to remove this from this area. And they all question me why we want to give these out to the patients. I said, but don't you think that the patient may ask you if those are clean, if those have been cleaned, are they contaminated? So the fewer areas we give a patient to question us, the better off we are, the higher in esteem we are. Sterilization area, again, great time to evaluate the flow, make sure that things are moving in the direction we want, make sure they're clean, make sure we have labels on our ultrasonics, and I can explain that if you'd like. Make sure that is the focal point of what a patient will see if, in fact, they ask to see us. Check your laboratory and restrooms. Again, you may want to make sure that some of them are not used for the patient, but you want to clean them after patient use. Again, we go into the McDonald's and the fast food places, and they all have a sign up that they when they're supposed to check those every hour or something like that. I encourage you, have certain checklists. I put together a whole checklist manual that you can have, both for the laboratory and the restroom. Those are key critical items. And again, take some pride in our staff room. Spruce it up, make sure that it looks the way we want it to. Take pride. That pride stems from that area. Once you assess it, then the reason is that the patients are looking at things. It increases our pride in the office. If we have pride in the office, we're anxious to go to work. We want our visitors to be impressed with our office because they, again, in turn, can help us grow our practices. We've got to really regrow our practices. There may be some patients who are fearful of coming in, so we want their perception and the visitor's perception and impression of the office to reflect the highest quality that we have. The boards may be visiting our offices more. Why is that? Well, don't you think that some of the patients may misinterpret some of the things that we're doing and may file complaints? That's a frightening prospect. So in order to avoid those, we go back to the sprucing up, the evaluation of the office, and we can minimize some of these. But again, once the board gets a complaint, they're mandated to investigate it. I'm encouraging you, please review the office, communicate our office as this. I put this in there so that you can understand what we want our patients to think of our office as: a safe haven, a virus-free zone. We want our employees to think about it that way too. Every one of us should be keying in right on the virus-free aspect. The virus is something we can't see. That's the frightening aspect. But if it's clean, if it's neat, if we wipe down our door handles and leave some of the doors open, in fact, that will allow us to have that communication of the virus-free zone. Establish housekeeping schedules. We've done that in the past. I know many of you have, but revisit those. Make sure that they reflect what you want. Enhance what things are. Again, as I said before, you're going to evaluate and increase your infection control protocols. One thing that I'm going to suggest is, if you have not been seeing patients in your office, this is a good time both to evaluate and update your infection control protocols, which we can help with, as well as a good time to do some periodic maintenance. And I suggest very strongly do the periodic maintenance, especially on your water lines prior to re-entering practice, because it would be nothing worse than re-entering practice, flipping on the water switch and having a broken pipe or a broken tube or something like that. So again, best time to do things is right now, when we're not pressed by having the patient obligation. Only use FDA approved products. This is where we're going to be really challenged. Why? Because there are I think most of us saw on the internet or different news about some of the KN95 masks being taken off the market. Did anyone see that? Probably out there, okay? There are many counterfeits out there. There are articles about counterfeit masks. Again, our ultimate goal is to protect ourselves in the office so that then we can be safe and protect our patients and protect our families. That's critical. Please check. I never, ever, ever encourage anyone to use anything that's not FDA approved. Very easy to go over that, very easy to check it. Much of it is online. I'm going to show you something like that. Examine your training schedules as well. We've had a lot of time to think. Thinking is dangerous. It's also very good, okay? When we think about what we do, we can think back and say, well, maybe we didn't really have as much training as we should. Maybe we can really now implement a schedule to train and emphasize the quality of our office, the infection control in the office, maybe even the post-exposures, or what we're going to do if somebody does come down with COVID-19 in our office. And I've got a separate little presentation I'll share with you on that. Encourage the increased training. Why? Well, federal, OSHA is going to increase the requirements for us. HIPAA, again, many of us have paid sort of, I don't know, lip service to OSHA, to HIPAA rather. We haven't really delved into it. And I've seen more and more HIPAA complaints because of carelessness, so I'll increase the attention to detail. These people right here, the state regulations, the boards, the commissions down in Connecticut, I know some of you may have or practice down in Connecticut, they call it a commission down there. They're all going to change their guidelines. Please make sure you stay in touch with them. Local guidelines, when we have an office in Springfield, it may have different requirements than an office in Holyoke or Westfield. And I'm going to let you know there are more stringent coming soon, more and more regulations. When I first started, way back before we wore gloves and masks and eyewear, there were virtually no regulations. We could open our office, we could just put up a sign, and that was it. Now, you have the OSHA, the HIPAA, the everything. The scary thing to me right now, I hope you all appreciate, is that the graduates, the seniors this year in dental school, the graduates from the hygiene schools, do you realize right now they cannot even take their exams? That's the impact that this has had, way more than we ever even dreamed of. So there are other people experiencing hardship way in excess of we are. Increased oversight. I'm sure that the states, the local governments, whether it be a public health commission or the like, are going to have increased oversight. When we look at things, I'm going to update here. I've got these right. I've got the whole plan all in place. We had put it in place last year. We put it in place last year because in anticipation of increased documentation necessary, increased awareness of the airborne transmitted diseases, and because of the fact that I was asked to do some work out in California. And they have this in place. They also have ergonomics, abusive workplace, so we can provide all of these templates for you all and customize them if you like, and that will be the documentation. What I want to make sure you all understand is this right here, change. I know it sounds silly, but change is constant. Everything is changing, not just today, but moving forward. What we're going to find is next week, it's going to be a different world with new regulations, inspections. Take some pride, and we have to have an ongoing need for ongoing preparedness. Right here, the fun begins. Everyone's looking at us. Infection control is a premium, airborne a necessity, and you got to read and research, and I'll show you what we do. Just as an example, this is what's a sample of what you need in your office right now in order to be able to wear that N95 respirator that I'm going to be speaking of very shortly. You do need something called an airborne transmitted disease control plan. In other words, education about it. You can see we talk about the respirators in here. We have the policies and procedures. So all of that can be simplified. We can cut lots of time off your effort. We have our table of contents for record keeping, and it goes into all of the accident investigations, airborne training, transmission screening questionnaires, and a little bit about our documentation, 10 little chapters. Actually, it's 10 long chapters, but they suffice to protect you from any of the regulatory agencies. Emergencies, you're going to be prepared. And this is what I'm getting into right here. One of the respiratory protective aspects called the N95 respirator. Have you all seen it? You may have. This is the original. This is the 3M version. NIOSH, I had shown you that at the beginning. It's labeled 1860. The FDA publishes a list of the approved N95 respirators. This is at the top of the list. They make a different version called an 1860S, which is smaller. These have to be fit tested. And I know there was a lot of confusion about that. So this is an example of what we utilize for a fit testing procedure. It's called a qualitative fit test. In other words, this is not worn for patient treatment, just so that you understand. The first office I walked into with this, the hygienist said to me, "Am I going to have to wear that to treat a patient?" I said, "No, no, no. This is just for the testing to make sure the mask fits properly." I'll go into that a little bit more. This is the material that we nebulize in. I use a bitter tasting material. Again, it shows and qualifies and clarifies that the mask that you place on, when we show you, and I'll show you how to place it on and take it off, is fitting properly and protecting you. That's the key. OSHA says if you wear those in the clinical arena, they have to be fit tested initially and actually annually, although they've relaxed that requirement for the hospital. It's done for you. We have an informational link for us as well. I will send this to you, just ddscovid.com. We compile lots of the different information in one simple website. And I put it this way, together we can move safely, put our information up there, but I'm going to get to that at the end. I just wanted to show you a little bit of that and then go into this little area right here. I like to use a different presentations. Always, I'm going to slide this over a little bit. I always put my name up there and my number just so that you can reach me. I hate to be inaccessible. So right there, again, my name, company is up there. Again, this is my personal, so don't hesitate, just reach out. This is the prior to the opening, and I told you that we were going to prepare you for the opening. So I've taken this, and some of you may recognize that it's from the ADHA, okay, American Dental Hygiene Association. Why do I choose the American Dental Hygiene Association? Because I think that they did even a better job than the American Dental Association on outlining the steps to prepare for opening. So I use it, and it really puts up certain questions and gives certain answers. So I encourage you all, meet with the entire dental team to have an open conversation. You can do that in person. You can do that via Zoom. You can do that via voicemail. I always say in person is really the best. We can walk through things. We can point out different things, enhancements that we've made. Make sure we have the current supply of PPE and any new supplies that are necessary. And everyone on this team can have input into those new supplies. We have the screening the practice, and we have methods to reduce or eliminate the aerosol production. Again, every office is going to be different. The orthodontic office will be very different than the periodontal office, which will be different than the general dentistry office. And as I mentioned before, the strategies for social distancing. This is something that our state has imposed, federally it's been imposed. I make a little joke about social distancing that if we really encourage it and enforce it to the ultimate, our birth rate will go down to 0. So that's just my kind of funny way of looking at it. But again, that was designed to flatten the curve. We're still increasing this. It's very important to do that. There may be schedule changes. Why? To allow for appropriate time for disinfecting. Where before we may have had a 45-minute time slot for the adult prophy, maybe we'll want to increase that and address the airborne particles that may be descending, the differences in the protective equipment, the differences in the disinfection that we're going to be dealing with. These are all important. The team should be there and review and answer the screening questions. Everyone, as I mentioned before, contactless thermometers. I'm hoping that you all have been able to acquire those. they're in short supply right now because everyone is demanding them. So again, those things should be recorded daily. I encourage more than daily, but at the midday point, again, people do get sick during the day. So we want to address some things like that. We address asymptomatic and pre-symptomatic transmission. Understand many of the people that are transmitting the disease may not exhibit signs and symptoms. That's important. We encourage everyone to wear a face mask. I had a funny question from this dentist was seeing an emergency patient, and the patient came in with a face mask on, sat down in the dental chair, and looked up at the dentist and said, "Do I have to take my mask off now?" And you look at that, and the patients don't understand. We have to invade the body. We're doing that. So we'll screen everyone for fever symptoms, screen the dental healthcare professionals. Upon the screening, if anyone becomes symptomatic, they should be sent home and tested and quarantined. Again, never hesitate. I encourage all the docs, all the assistants, all the hygiene people, please make mention of things. Don't be bashful. Have things come out. Our whole goal in the office is to protect everyone, not just the production, not just the patient. It's all of the staff members and ultimately all of the staff members' families. Team members should leave their clothes or leave their footwear in the office. So again, some offices are having people change in the office. Some people are having them leave their footwear. Some are having them wear the booties. Whatever works for your office. That's the important thing. We have to understand every office is going to be different. The 6-foot social distancing, wear the protective eyewear and masks, even when you're not in the treatment area. Now, this is an entire flip of what we had prior to this. Prior to this, everyone was told, don't wear your protective equipment out into the non-clinical area. The bottom line is everyone in the world, well, everyone in our country knows what PPE is now, don't they? Yeah. If you asked your patients in January what PPE was, they probably wouldn't have a clue. But everyone watching the news knows what PPE is now, and they're going to be looking at us with microscopes, with magnifying glasses. This is critical when we reinstitute the use of ultrasonic scaling in our hygiene program. High volume evacuation available during the hygiene rooms, maybe even an assistant, maybe even different. As we sit here and speak right now, there are many more of the items that are being developed that will allow us to minimize the aerosol production. In other words, different new techniques, new machines that will be able to suction away things immediately rather than have them aerosolize. Clean and disinfect the public areas, waiting rooms, store handles, as I mentioned. Remove the unnecessary objects. You can see the toys, magazines, contamination in the reception area. Many of us will replace our reception area furniture. Why do I say that? Well, many of us have cloth items there. They're very difficult to disinfect. We're very concerned about the impression that we make and give to people. That's a critical thing. We can see over here with regard to patient preparation. Step by step, we want to have telephone or video screening. Again, many offices are instituting that. Most of the time it's telephone. Ask specific questions with regard to COVID-19. Have they contacted anyone? Again, yesterday I was in an office and I was asked, we were doing fit testing for the office, and one of the people couldn't be there. She couldn't be there because she's a hygienist and her husband just was diagnosed with COVID-19. So by virtue of her living with him, she was quarantined, she was tested, and we're awaiting the results. And we always contact the public health officials to know what to do. So we ask if anyone's been exposed, have signs or symptoms of the disease, and I'll show you the checklist that we use. Patients, we don't want them in the office. I'm not going to read this, but we don't want them in the office until we welcome them in. until they're admitted into the office. In other words, screened, whether it be temperature, whether it be the screening form that I will show you in a little bit. We need them to be safe to welcome them into the office. And even then, we may not want them in the reception area. We may want to have them wait outside if there's a waiting area, wait in their car. Maybe we'll text them. Maybe we'll give them a beeper like they do at Panera or something like that. Your appointment is ready now. And we'll guide them right in. We don't want them lingering. We don't want them to bring their whole family into the office with them. Again, it's challenging, specifically in pediatric dentistry and orthodontics. We typically have families come in together, but we are going to encourage our patients not to bring in their designer coffees with them. Typically, especially in ortho, we've done our bandings in the morning. The parents will bring in a cup of coffee and sit and watch everything. We don't really want any extraneous items, any foreign objects into the office. That's very, very important. Anyone that is accompanying should really ideally wait outside, and you'll actively screen everyone for signs and symptoms. And this is the magical temperature right here, 100.4. I'm sure you all know that. It's been on the news repeatedly, but that's the temperature. If they have a temperature above that, then we should ideally not treat them in the office on that day. And I think most of the public knows, but some will get upset. So be prepared for people being upset. Unfortunately, tempers are running short right now, but this is critical. I'll get you this whole presentation so that anybody can have it. You can make notes on it. I probably should have gotten it to you before, so you could have made notes, but nevertheless, I have it in a PDF format. Be more than happy to send it out. If forms need to be completed or signed, please instruct them that we have the pens, keep them for their personal use. We could disinfect them. I'm encouraging most of the offices, if you can do things electronically, please do them. We can do them prior to the appointment. We can do them at the appointment. Even payments. View your payment processing, see which ways we can have patients prepay for things or have contactless payment. Again, our staff is so important. I get so many questions from the business staff. The business staff is almost at the front line. So I don't want to neglect the business staff in this. Most of our offices were built without the barriers in the reception area. In other words, an open desk. Again, that's kind of threatening in today's world. Even when you go to the market, you see the plexiglass screen right there. I'm encouraging people. I was just in an office yesterday. It was just built in January. Has that big open area in the reception area for the business staff. And now they had to put up movable plexiglass screens. Again, if you want, we have different resources that we have available. We can guide you to those if you'd like. When you look over here, you see the dental healthcare personnel, assistants, hygienists, very high exposure. Unfortunately, that's the case because as I explained to you at the beginning, we are the ones placing our hands inside of the mouth, and even a breath, even a cough, even the use of an air water syringe can cause an aerosolization, not necessarily the disease. So we perform critical tasks, everything that's our clinical treatment. And that's important to understand because our orthodontic people, they really don't penetrate any tissue. They're not doing that, but there's still the saliva aspects, there's the breath aspects, and things like that. And you've all heard, I believe, about the pre-procedural mouth rinses, and I'm going to get into that in case anyone has any questions. I think there were some that were posted earlier. Non-critical is something that cleans the operatory. It's the basic cleaning of the office. Yep.
Howard, may I break in for a moment?
Yeah, sure, certainly.
We have a couple of questions, and I know, Ben, you have a couple that a number of our participants have asked. The first one, let me get two of them out of the way quickly.
Yeah, sure.
The mask testing, and we know that some of the requirements have been put on hold, but there is still a requirement that you need initial testing. The first
Correct.
question, is that correct? And if we were to start next Tuesday, if we didn't have it tested, do we have some leeway on that or not? And then the second question was the fogging that a number of people have been talking about, fogging their office.
Yeah, yeah. With regard to the mask, you are correct. The mask, the initial fit test must be accomplished. Is there some leeway in it? Most likely there is. I've contacted OSHA, the local, the Region 1, as well as out in Ohio, where I've got a lot of clients, and they've said that they're not going to penalize people immediately, but they do expect some due diligence, and that be done within what they gave me a reasonable amount of time. I asked them what a reasonable amount of time was, and they couldn't really say 2 days, 3 days, 2 weeks, a month. I would say if it's done within the first month's time, it's probably okay to do. And we'll endeavor to get to most people. As far as the fogging goes, the school is still out on that. We're not seeing the evidence that it's going to be a requirement. It's more the air purification that we'll look for, the HEPA filtration and things like that. So as far as that goes, I'm researching, I'm trying to get more information on the actual cleaning, quote unquote, the fogging of the room. Ben, did you have any questions that you want to address right now? I could look at some of the chat if you'd like as well. Anything? Oh,
A lot
okay.
of questions,
Yeah.
Howard, about air purifier versus an
Yeah.
air filter.
Yeah.
Operatory.
Yeah, and again, it depends on the office. I know that's a cop-out, but every office is designed differently. We've got some designed from the 1950s and 60s, and we have some that are current, up to current standards. So it's going to depend on your individual facility as to what's necessary. I can tell you, I deal with a gentleman who happens to be the Region 1 representative from the ADA, and he has a certain system of air purification in his office. It's also used at some of the dental schools. I don't like to give out names or recommendations, but I can refer you to different ones if you'd like, and that's what I would do. Again, you have to do that as I come back to what my initial presentation, the initial evaluation of your office. Find out really what it is and where to go, what's the best. Is it UV penetration? Is it HEPA filtration? Is it all air system handling or different things like that?
How about HVAC systems, Dr.
Yeah,
Pactovis?
well, I
Those need to be
encourage, there
treated?
was one question in there about what exactly does the HVAC system cleaning or maintenance entail? And you know what? The HVAC system individual does that. I have a very close friend. He does all the HVAC for the Shriners Hospital here in Boston, and he comes to my house and looks at it. And I'll tell you, it's a real different job than the traditional air conditioner maintenance, air conditioning, heating maintenance. So I always say, look, search out qualified individuals. Sometimes your supply company can give them to you. Sometimes your building can give them to you. And we're compiling a list of preferred representatives. So again, there's no, I try to deal with the things that I know and try to refer the things that I don't know.
So right now there are no guidelines regarding air purifiers, air scrubbers, filtration.
No, there aren't. And this is where we're, sort of left in the lurch, because there are so many of the gray areas, so much that's unwritten and not understood and misunderstood, that I encourage you, I would say at this point, do not spend tons of money on something that you don't need, okay? Because you may regret it later on. So evaluate what you have, put in place what is required, and I can get you that, what is required, and then evaluate some of the different ways of moving forward in a safe and I'll call it cost-effective manner. Because again, we can put ourselves out of business by just putting something in place that is either not necessary or not appropriate for our facility.
Howard, it's Mike Cabin here.
Yes.
Getting a few questions about HVE systems, enhanced HVE systems to reduce aerosols. Can you speak
Yeah.
to that for a second?
As I said, right now we've got some really innovative people and companies working on high volume evacuation, add-ons to the ultrasonics, different things like that, to minimize the that spray, that spatter that comes out of the ultrasonic. Right now, we're minimizing the use of that. So consequently, we're going to wait and see the trials that come out, see the new products that are coming out, and then we'll be able to implement or make suggestions as to the best way to move forward with that. But I had a question from an office earlier today. They said, will we ever really be able to use the ultrasonic again? And I said, yes, you will, because we will have something new that will be developed, something that maybe we haven't even thought of. Some 13-year-old is probably going to invent it, you know that, as far as those things go. And we will have different things. So the whole world of dentistry is going to change. That's what I want you to be aware of. Right here.
One more, Howard.
Yeah, sure.
One more related to this. So we're getting questions. Obviously, PPE is difficult to come by right now. No one wants to do the minimum, but what is the minimum required level of PPE that we need to be providing our staff at this point?
Yeah.
I know that's a tough one.
Yeah, it is tough, and I don't want to get pigeonholed. I would say it's going to be task dependent. In other words, how much of the aerosol is going to be there, how much of a risk we're willing to take. I can get articles and I'll get them to all of you. And they're not my recommendations. My recommendation would be the use of the N95. However, as Dr. Cabin pointed out, yeah, they're hard to come by. You can't get them. You'd have to mortgage your life in order to get them. Can we step down to a level 3 mask? I have articles that will show that we're just as safe with the level 3 mask and a full face shield as we are with the N95. I'm not sure. I haven't vetted it. I haven't made sure that it's totally accurate, but it is in one of the respected journals, and I'll be more than happy to provide that for you. What I will tell anyone on the call on this is I don't want anybody taking a chance that they don't want to take. I will tell you that you're safe in the office, regardless of whether you use the level 3 mask or the N95. But I don't want anybody to think that they're 100% protected no matter what PPE they're using. So I know it's a cop-out, but that's about the only way that I can say it. Yeah, Mike?
No, that's a good answer. Just a couple more. People are focusing on the HVAC again, running the HVAC system in your office. Is there an issue turning on the air and heat?
There shouldn't be if you have the if you have the maintenance, and that's what I had talked about initially, doing the annual or the maintenance that we do on ours. Many of us haven't done that, so that's something that we should really revisit in every office. Make sure that it's working at optimal levels, and that the filters are changed, and that we're not going to put anyone at risk for recirculating air that may be contaminated. If they can give us some kind of a security or increase our filtration, that's what I would go with in terms of protecting everyone in the office. So that's my feeling about it. Again, I'm not an HVAC specialist or anything of that nature, and I'll defer to anyone that is, but they will be able to give you in your each individual practice the appropriate mechanisms and they can even test things. They can monitor, they can test, and that may be something that that would be a good idea in every office, to really evaluate where you are and where you'd like to go, and that can determine what improvements we'd like to make. So what I want to talk about moving forward is the N95 respirators. This is the training on fit, should be fit and seal. The seal is the aspect that I was showing you with that fit test kit provided prior to use. Again, little things like that. Respirator before entering the room, put on the N95 or a respirator that offers a higher level of protection. Again, we want to be protected. If we can't get one, are we going to just stop doing treatment in the middle of a treatment or in the middle of a day? Again, hard for me to make a qualification or a justification on that, but nevertheless, we have to evaluate what level of risk are we willing to take. I get in the car every day and I drive to offices. There are people going around at 90 miles an hour, weaving in and out. Am I taking a risk getting in my car and driving with them? I certainly am. Do I assume some of that risk? Do I try to move forward with that? Do I practice and do I drive safely? Yes. That's what we have to be a little bit introspective. We have to ask ourselves, how are we protecting ourselves? What levels can we get? Are we really getting exposed to the airborne particles if we're wearing even a step down mask, a level 3, and I encourage the glasses and another mask over the level, and not another mask over the level 3. I'd encourage another one over the N95 and the face shield. I'm really encouraging the face shield to minimize the active spray into the facial area. See what see what they say right here. This is right from the hygiene people. If a respirator, this mask right here, is not available, use a combination of a surgical mask, as you can see, and as I've illustrated, oops, sorry, I went the wrong way. I just wanted to move this a little bit, and a full face shield. So again, I'm going with the hygiene guidelines. That's the key. That's what, and the hygiene guidelines are designed to protect that hygiene individual and their patient, and really virtually everyone in the office. So this is what I'll hang my hat on from there, as well as the N95. During aerosol generating procedures, use of a handpiece, air water syringe, ultrasonic scaler, that's when you need the N95 or a respirator that offers a higher level. They make N99s, N100s, filtering face piece. We don't really use those in dentistry, but that's the aerosol. If we minimize the use of the ultrasonic, then we can step down. Again, I don't encourage anybody to take a risk that's unnecessary, but we realize that our societies are endorsing, our associations are endorsing certain things. We can see that we identify, gather information on the gown size, make sure that things are correct, hand sanitizer. This is the step-by-step in putting things on. And when I train on the N95, it's very specific in the way it should be placed on. And that really is critical. You can get videos on it. We have a video coming out as well. But we do a demonstration in the office so that everyone knows. Actually, I'm doing we're putting together a full day training for another one of the district dental societies so that people can bring in their own N95 masks and have them fit tested, different things like that. So we have lots of availability to do things with you and for you.
Howard, can I jump in with regards
Yeah.
to those masks? I know a number of our members and a number of staff have, we're limited with the PPE and certainly the N95s at the present time. We need to conserve them. Is it appropriate for us doctors to recommend that when we dispense or distribute our N95s or KN95s, that how do we extend their use? Certainly a secondary level 3, but do we use them and reuse them? Please talk about that.
Here, since you asked that, I figure let's step forward to the mask, because again, between the HVAC and the masks, that's where the questions are. That's where they arise. COVID-19, we need some creative solutions for repurposing or prolonging the use, growing influx of new information. This is what we're doing. We're going to provide, update regularly new information. You can see that right on here, the mask is ideally used for a one-time use. CDC, NIOSH don't formally recommend the reuse. However, right here, you see that word scarcity? We're in a time of scarcity, as Dr. Mariano mentioned. Very, very important. And we can discuss options based on individual clinical judgment. And you can see the mask, just so that you understand what it does, it captures at least 95% of particles. This is 0.3 microns or greater. That happens to be the size of a tuberculosis spore. However, we look at the viral particles that we're dealing with now, they're tinier, okay? However, the motion and the filtration, mechanical and electrostatic, in other words, these are tested. They're approved by the FDA to do the job. Okay, the outer mask is hydrophobic, generally rejects water, and now extended use, reuse, and reprocessing are available. It's important to differentiate between extended or reuse and reprocessing. You've heard about reprocessing. There are machines that are out there. Company right here in Massachusetts, I think, developed that. Unfortunately, they're about, cost about $8,000-9,000, and they're mainly for the big industrial, the hospitals and the like. But the CDC says prolonged use of the mask, including between patients, can be safe for up to 8 hours. That's important. That's the key factor. That means all day. So when we hear the emergency room person say, oh, they only gave me one mask for the day. You know what? That's what they needed. So that's what they got. When you hear the ER person say, we only have 2 weeks of PPE left in the hospital. You know what? They never had more than 2 weeks worth of PPE. They wouldn't have room to store it, nor would you. But the current guidelines encourage wearing the face shield over the N95. I encourage also wearing another mask, a level 1, 2, or 3 mask over the N95. Again, to Dr. Mariano's point, what we want is we want to preserve the mask. We want to preserve its integrity. We want to preserve it from getting contaminated. So in order to reuse them, let's look at it. Coronaviruses lose viability significantly after 72 hours. That much they know. So on the surface, the coronavirus, whether it's on the mask, whether it's on your surface on your countertop, after 72 hours left alone, it will probably die. Assuming there's no soiling of the mask. In other words, they're not physically, visibly contaminated. And minimal contamination, CDC says the mask can be reused, you can see right here, up to 5 times. How do we do that? Well, one simple way that I recommend to most offices is to get a set, at least 5. Why do I say 5? Well, typically we're working a 5-day week, okay? And allowing them to dry. When you allow them to dry, the virus dies by itself greater than 72 hours. Proper storage, you can either hang them up, which I think is kind of gross to come in and see them hung up because then they're exposed to other airborne particles. But I believe in this, keeping them in a clean, breathable container, brown paper bag, okay? We have lots of access to those in between use. Make sure masks don't touch each other. So in other words, the bag, 1 mask per bag, leave it for that amount of time. So my suggestion to most offices, say you're working a Monday through Friday schedule, have 1 mask per person per day, and you label the bag Monday, Tuesday, Wednesday, Thursday, Friday. And next Monday, you can use the Monday mask. So for that month, you can use that 1 mask on Monday, 1 mask on Tuesday, 1 on Wednesday, Thursday, and Friday. And that is a way to legitimately prolong the use, extend the use of the mask. So again, very important question, very important to understand what we're doing, how we're doing it, and how we do it safely.
Howard, jump in again. The
Yeah.
same question regarding our disposable gowns, because many times I know in previous, many of us had our beautiful white coats and we would go from patient to patient and we didn't even think twice about it. Now with all of the disposables over us, do we change them in between patients? Do we look to
And-
when they're soiled this way? Can we go between patients with them? That's another big question, similar to the mask question.
Right, and it is. It's a huge question because we're getting a lot of, I'll put it this way at best, confusing information. And the confusing information is it says that the gown should be changed after use. Well, after use is after the day's use, not after each patient's use. So we're very careful about how we use them, how we don't visibly contaminate them. If you look at the ER, when you look at the ER, the pictures on TV, you don't see them changing their gowns between patients. That's the key. That's the same way that we're utilizing them. We utilize them pretty much the same as we did in the past. They may be a little bit different consistency. You're going to get varying ideas about them, but I venture to guess that in an orthodontic office where you're seeing 30 or 40 or 50 people in the afternoon, you'd probably be hard pressed to have 30 or 40 or 50 either cloth or paper gowns to change in between each patient. It's not like we're on the movie set where we have to have multiple costume changes and things like that. So the answer is, the recommendation is to change them. And I'll go back to that in a second. I think it's right back here. Let me get back here for a second. Yeah, it says discard disposable gowns after use. That's what it says. What is use? Is it one patient? Is it one morning? Is it one afternoon? Is it one day? And traditionally, it's always been one day. I don't believe that's changed. You'll launder the cloth gowns after each use. That means the day's use. We don't, if there are shortages, prioritize for aerosol generating. We're not going to have a shortage of the gowns. Clinical procedures where splash and spray are the thing. Gloves are changed all the time. So again, you can see it's fairly uncomplicated that we're going to be moving forward virtually the same way. Our big change is going to be in the masks, and the shields, and the headgear, and the shoes. So that's what I illustrate.
Howard.
Yep.
Sorry, quick one on the masks still. I'm being asked if providers are wearing a level 3 mask over their N95. Is that being changed patient to patient? The over mask?
The outer mask is the same way as we would change that between patients, okay? We could wear the N95 mask for the entire day if you could breathe. They're very, very constricting. So you have to understand that many people might even have some oxygen deprivation. In order to wear an N95 mask in the clinical area, you have to be medically cleared. You have to fill out a medical clearance questionnaire to make sure you're healthy enough to wear the mask. That's critical. Someone with COPD might not be able to wear the mask. A gentleman who has a beard, a big heavy beard, cannot be cleared to wear the mask because they would never pass the fit test. It would allow too much of the fit test solution to get through. They would inhale it. So I've had to have gentlemen shave their beards. So the fit test entails a medical clearance, a test to make sure it fits properly, and they can wear it for the 8-hour day, as I said right over here. The 8-hour day, that's what they're designed for. Where is it? It was right back here somewhere. On one of these, 8-hour day, let me move this right around here. You'll be able to see it again. I'll move this to the other side. I gotta just slide myself over here, and we can do that so that you'll be able to see those things. Right over here, really critical how you put them on, how you take them off. And there are many different ways to do it, but I describe one when I come to your office and show you, or you'll see it on our videos that they come in when we get them to you. But again, this is the thing: mass decontamination, investigated by the CDC, sufficiently inactivate the viral load. 3 days does that. Can't be soiled. In other words, don't wear the makeup. I showed you that at the beginning as well. Body fluids, electrostatic charge be preserved as much as possible. All of these things are vitally important to what we do. I'm gonna move this back up here again. I'll move myself over there. Fit of the mask can't be compromised. I don't want to wear anyone else's mask. That's the danger with sending them out to be reprocessed, something of that nature. Most studies in N95 decontamination were performed with the flu virus or bacterial spores. So we know that they're fairly accurate. Recent publications have started testing for the SARS-CoV-2. What I want to show you is a little something right over here, just so that you can have some sense of security. Right over here, many of you use a product called Cavicide, Cava Wipes, okay, in your office. This is right here from the company that makes Cavicide, Metrex. And it's really interesting, and I encourage you print this out, or I'll print it out for you or send you a link. And they talk about it, the efficacy of the disinfection on COVID-19. Really interesting. At present, they say no EPA recognized test protocol to evaluate the disinfection. They go on and describe it a little bit about what it is. But what I point out is right here. It says, even though SARS-CoV and human coronavirus and SARS-CoV-2 are not same virus strains, we note that all coronavirus strains are enveloped viral particles, and they belong to the same family. That's important to understand, okay? If they belong to the same family, they realize that enveloped viral particles are very typically more susceptible to chemical disinfectant than any other common pathogens. So in other words, they're fairly easy to break down. That's really important. Here from the EPA rather, is a list of disinfectants used for SARS-CoV-2. Have any of you seen that? It's one of those that's published, it's linked to. I'll send you the links to it. It's very interesting because they publish right here the products that will be used for SARS-CoV-2. And you can see they'll list the name of the product over here if you expand this, and the time and minutes and everything like that. And they'll go into what they are. We can see hydrogen peroxide, sodium hypochlorites. We know that's the bleach. And this goes on and on and on. Each one of these is about 20 items each list, 20, 25 items on the page, and it goes on for 17 pages. When you look at your household products, you'll see something like maybe the Clorox wipes or something like that. Many of them will be active against human coronavirus, not necessarily SARS-CoV-2. Okay. However, as I've shown you, those are pretty much active against them. I thought I would take another moment and show you this right over here, which is what happens if a staff tests positive. And I'll go back up to the top of the presentation, right over here. Again, some really, really good stuff that we have to be aware of. What are we gonna do? And we're working in a workplace and one of our staff members tests positive. So I thought I would address this as it's one of the big concerns that a lot of people have. Right here, once the diagnosis is confirmed, follow all the medical recommendations. In other words, we're not the physician. I don't make the determination, quarantine, different things like that. Seek medical treatment, obviously, if symptoms worsen. Again, common sense, but I emphasize common sense isn't really that common. Try to determine who might have had contact with that now positive individual. That's the key thing. We're trying to do that in the state with tracing and contact tracing and different things that you may have heard of, and notify the staff of the diagnosis. Questions asked: when was the date of last contact? How long was the contact? This is critical because they feel as though just a fleeting contact may not be enough to transmit that disease. However, we're not entirely positive, but the longer close contact, the more likely it is that that might happen. What was the approximate distance? And were they across the room? Were they right, holding hands? Were they 6 feet apart? Were they 7 feet apart? Are they experiencing that individual that they were in contact with, experiencing symptoms? Good idea to instruct them to notify someone immediately if there's a change in symptoms. Again, that openness that we have with staff, whether it's in evaluating what we have, whether it's in implementing, whether it's in training, emphasizes the working relationship. Conduct a risk assessment. And this is the important for any healthcare provider who is exposed. And this is what it is. It's called the U.S. Interim Guidance. And I'll show you what it is right here. That's what the document looks like. And it's not really that lengthy a document. I can say that because I've seen some that are hundreds, if not thousands of pages long. And it goes into this, the epidemiologic risk factors, and I've circled a couple. Was the healthcare professional not wearing a face mask or respirator? And again, for that exposure, it's a medium exposure category. Again, it's kind of interesting that I would think that was high, but they list that as medium. And then they say exclude for work for 14 days after the last exposure. In other words, the last exposure might have been 7 days ago. That would mean that would be included. We can see the prolonged contact. This is with a prolonged contact that happened about 48 hours, okay, beginning at 48 hours. This is prolonged contact with a patient beginning 48 hours before the symptoms, who was not wearing a cloth face covering or a face mask. And we can see that, again, if you weren't wearing any protective equipment, very high exposure. Even not wearing a face mask or respirator is high. If you're not wearing eye protection, but you were wearing the face mask, then it's medium. And then it goes down to low if you just weren't wearing the gown or gloves. Very interesting how they assess it. These are the public health guidelines. We can see the revisions were made back on about 2 weeks ago, April 27th. To address the asymptomatic, implement the source, require face masks or cloth face coverings for anyone entering. And this one is really critical. That's the important thing. That protects us from them and the healthcare professionals, regardless of whether they have symptoms or not. Actively screen everyone, which we do, and screen the dental healthcare professional before every shift. I say the middle of the day too. Again, we give you all the checklists that you can utilize. Right here, you can see, ask the unaffected staff to seek the attention, contact all patients who've had contact. I've circled some of the important things in that public health document. And the key thing right here is this: follow the recommendations of the CDC and these people here, local public health authority. Again, they're the ones who govern, who make the rules, who help us out. They're there to answer our questions. Please have communication with them. This is important in both tracking the disease as well as keeping everyone safe in the office, and that's the key thing. Here are the interim infection prevention for suspected or confirmed coronavirus, and you can see there's a website. I'll send it to you. And I've circled a few of the important things. I think they're really important. This is take precautions when performing aerosol-generated procedures. In other words, wearing the protective equipment, having the right suction systems available, manage the visitor access and movement in the facility. This right here, I encourage every one of us to do, both today and moving forward, is train and educate the healthcare personnel. Really a vital thing to do. Everyone should be trained. I'm glad Dr. Mariano didn't take his phone into the restroom like the Supreme Court did. Did everyone hear that the other day when the Supreme Court held oral, no pun intended?
You're very observant.
Yeah, I noticed you disappeared from the screen, so I thought you either went to get a cup of coffee or to Well, never mind. We won't share with everyone. It's personal items right there.
I know Mike has a question back on the gowns. Mike,
Yeah,
jump in because we've got
yeah.
a lot of feedback on your gown comment.
Yeah, I have two questions related to that. I was just about to jump in. So on the gowns, I want to confirm this point that we're being asked. So obviously, the gowns are procedure dependent. So you're in with patient one, you don't create any aerosol, you're just doing a quick check. You're okay to then go into patient two with the same gown. However, now you do an aerosol procedure with patient two, you've got to now change your gown before you go to patient three because now you've brought those particles onto the gown that you're wearing.
Not exactly true, because the particles are going to get on even from someone who's doing an aerosol procedure outside of that area. We don't know where the particles are. So once the gown is on, it's worn for the day. Okay, it's taken off to go into the staff room. It's taken off to if you're going to sit out in the reception area or something of that nature. So that's how I interpret what the CDC has said and what I've got from them.
Good. One more relative to this.
Yeah.
We're getting this question coming through a few times now. The comparison of the level 3 mask to the N95 mask, where the filtration is acceptable on the level 3. However, since you're not fit testing it, are you okay with that? You know, the N95 versus the level 3 mask with, let's say, a face shield.
Excellent question. And the level 3 mask cannot be fit tested. It's not suitable for fit testing. So it's not going to give the same level of protection, and we know that. That's why right over here you can see the face mask and PPE referred to as surgical masks. This is why I put this up here. They're typically used for face masks. Not over here, not regulated by the FDA. Some procedure masks typically used for isolation. They protect mainly from the particles, more so than the sprays, and more so than the viral particles that we're seeing. This respirator is a protective device, very different than a piece of personal protective equipment, worn to cover the nose and mouth, reduce our risk of inhaling hazardous airborne, including dust particles. Some of the N95 masks that we see are sold in Home Depot and Lowe's, and those are ones primarily for industry, for dust particles. We're wearing the ones for this, for the infectious agents. We don't wear them for the gases or the vapors. Respirators are certified, as you can see, by CDC and NIOSH, including those intended for us, the healthcare people. And you can find a list, and I can send you a list of all those that are approved. The ADA publishes one. That is very complete, but that's the difference. The face mask, the traditional face mask, whether it's level 1, level 2, or level 3, the primary purpose is to protect from the particles that may be getting into our facial area, getting into our nose and mouth, things like that. So they repel those particles. They don't allow them to penetrate. They're not designed to filter out the very fine, either tuberculosis spores or the viral particles that we see that are very, very tiny. And the mask itself, the respirator mask itself, is certified by these people here, CDC and NIOSH, to perform its duty, to perform its goal. What isn't performed by them is how it fits on your face, or Dr. Mariano's face, or Dr. Falk's face, or my face, or any one of our employees. And that's why we've got to demonstrate that our employee is safe by the proper placement of the mask, by doing what we call a qualitative fit test. So those are the differences. The paper mask that we see for the level 3, for example, is not able to be fully adapted to the face and filter out the particles, let alone the side aspects of it getting, allowing the close fit that the N95 mask would. If anybody's worn an N95 mask, you'll find that it's very, very it almost causes your temperature to rise. Very warm, almost encourages you to sweat a little bit. So it's going to take some time to get used to them too, but have them fit tested. Dr. Mariano, you have a question, comment, or you were
Well,
on?
I think we got to put this gown question to bed because
Yep.
there's still a lot of questions. But my reality is, right now, the disposables, at least in our office and from many of our members I've heard, are in demand. We can't get them. So they are a supply, just like the masks to a certain
Yes.
extent.
Yeah.
We are
Supply chain.
supply issues. So we are all grown-ups. And I am telling my staff that, hey, listen, you're given that disposable at the beginning of the day, but listen, if you feel that it has been compromised during the course of a patient care, then you have the right to change it out. And you don't want to go into another operatory if it has been damaged in any way, or you feel the aerosols. But maybe a lot of this is up to interpretation, CDC versus ADA. But give us your thoughts.
Yeah.
I don't think we have to force staff to do it. I think they have to have a little bit of ability of movement on that.
No, the whole, you're right. The supply chain is broken, whether it's for our gowns, whether it's for our meat products that we're seeing, whether it's for toilet paper that we've seen. So we don't always have the availability of things, but the gown only really becomes compromised when it's visibly contaminated.
Yeah. Okay.
And that is the hallmark. That's what we've dealt with for years and years and years. And that really has not been changed. The reason that it hasn't been changed, at least officially changed, is because of the fact that none of us can see the virus. None of us know where it is. We don't know which particles in the air may carry it, which molecules may be there. So consequently, we work under the assumption that unless something is visibly contaminated, it's okay to use, and that's how we go. So that's as clear as I can say it, as
Yep.
clear as I understand it.
Great, thank you.
No, you're welcome. This is the key thing. Healthcare professionals wear a face mask at all times while you're in the healthcare facility. It doesn't have to be that N95 mask. You know that. That is preferred and preserved for the patient treatment. But the face mask, again, very, very different than what we wore years ago when we told people, take it off when you come out of the clinical area, things like that. So that's the important thing. And there's the example right here, COVID-19 PPE. As you can see, the preferred PPE is the N95 or higher, could be N99, N100. See, face shield or goggles. I emphasize face shield and goggles. There's the mask right there. One pair of clean sterile gloves and the isolation gown or the disposable gown as we see. Acceptable alternative PPE. And this is, again, as you can see, from the CDC, right from there, cdc.gov, acceptable alternative face mask, the face mask, the face shield or goggles, N95 or higher, one pair of gloves, and the isolation gown. Not really a significant difference, but the face mask is different than in here. They're recommending the N95 or higher, although they do say it's acceptable to wear the level 3 face mask. So that was that little section that I wanted to show you right over there. I thought that it was pretty interesting. We want to go for a little bit longer, or we have a multitude of questions. Let me know what you'd like to do.
Mike and Ben, why don't you go start going through some of these questions?
Yeah.
I know there may be a few more.
Sure.
Have some. I can look at some of them too in the chat if you want.
Okay, let me jump in while
Yeah.
Ben and Mike, while you're looking at that. We've had some guidance today from the MDS, Howard, and I know you're aware of it, but there's this new word that has come up, and I'm going to read it. Dental offices, based on the recommendations today, obviously we're waiting for the governor to move forward with some sort of additional recommendations on Monday. But it says dental offices should continue to only treat emergencies and urgent cases, only at the start of phase 1, and we're going to know when phase 1 starts on Monday based on what we're hearing from the governor's office. And the new wording is dentists may start treating in phase 1 emergent and likely to become emergent cases. Does that word emergent, it seems to me that that wording purposely by the MDS is giving a little bit more leeway to us dentists. I know some of the some of the recommendations that the MDS has also given already during urgent care is ongoing care. So patients in provisionals, a case which has been started, we could finish that case because that patient is in provisionals and needs to be finished since it's been 2 months. But what do these words mean? Have you thought about what that definition is?
Me, me in particular, or anyone on the call? It's really open to question. Emergent could be that, as we say, we provisionalize someone for a couple of months and we don't want to compromise the fit and form of the final restoration. It could be your orthodontic patient who hasn't been seen for a couple of months and there needs to be adjustment. That I would consider emergent. I think it's going to be dependent on the individual operator and individual office. And Micah's smiling there, thinking, well, anybody could be emergent. And I think that anybody could be.
And it says likely to become emergent. So I saw an X-ray today on an emergency patient where there was a crack in the tooth, there was decay. If that isn't treated, that would be an emergency maybe in a couple of weeks. So I do believe that providing you're meeting CDC guidelines and state guidelines for infection control and have the PPE, that I believe we're going to be entering an era of a little bit more flexibility and leeway, simply because we've had such a backlog of emergencies. Obviously, in many of our offices, many more emergencies calls are coming in now over the past few weeks. So I think certainly the purpose of this presentation is to get all of us up to speed, so when we do open on this slow rollout, which is going to begin within the next week or a few days, that we are prepared. So Mike, question, or Ben?
Yeah, I have something here. This was being asked, I think, possibly from our pediatric dental friends and orthodontic friends here. Aerosols in a larger room when we're practicing in an open bay type setting versus in a closed room like you would see with our general dentist friends, and the aerosol spreading throughout our clinics. Can you address that?
Yeah, great question. And as I stated at the beginning, I do feel as though the big challenges in re-entry to practice are going to be the orthodontic and the pediatric dental practices. When you think about it, we do have much more of an open type of a situation, which the newer offices moving forward will not be built that way, but we have existing offices that we're dealing with. Aerosols, again, they don't travel in, they travel in straight lines, or they extend in a cone-shaped manner. They don't curve around and go to another chair that might be 90 degrees from that. So we've got to think about aerosols in that area. And this is where social distancing and dentistry might intersect. And in other words, if you've got an orthodontic office with 4 chairs lined up, one right next to the other, maybe I would suggest initially to utilize every other chair or something of that nature, similar with a pediatric dental office. Again, we've got to evaluate our own situation and come up with the best solution, but realize which way the aerosols move. Again, they're not heat-seeking missiles. They're not going to come and attack us if we move by. They are going to go out, and then they slowly descend to a surface. This is the fact that they're looking at right now. They're doing studies. How long do they take to descend? What are they doing? I'd like to answer this question here. I got one that somebody had written in that come up about the ultrasonic cleaner. Is it appropriate to use? Yes, it is. The cover should be on it, okay? Again, we want to minimize aerosolization from that. Should there be zero hand scrubbing? again, I try to emphasize the use of the ultrasonic or the instrument hand washer prior to doing any sterilization. But an intermediate step is inspecting the instruments, making sure there's no debris left on them. In that case, there might have to be a little bit of touch up with a hand scrubbing, but by that point, you've removed most of the bioburden. What's the possibility? We're opening on May 18th. I think Dr. Mariano addressed that. The Mass Dental Society has. I don't think there will be anything pretty much as routine dental care moving forward. Okay, it'll either be emergent or elective. I think that's what they're going to be calling it. So I don't think routine is in the operable words for the state legislators to be looking at. And what exactly is the HVA system consist of? Again, I'm not expert at that, and I would recommend that you go to your provider for that. Read OSHA follows CDC guidelines. OSHA does follow most of the CD guidelines. More important than that, your state board follows the CDC guidelines. That's where you've got to be much more aware. The state board has all the guidance over your license. The regulations are all promulgated from the CDC guidelines. OSHA does follow a lot of them, but OSHA, very interestingly, is only for the employees. So that's all OSHA's concerned with. If a patient complained to OSHA, they would say, we don't care. We're not interested because you're not an employee. That's the key. Anybody remember the hotel that collapsed in New Orleans, and I think 3 people died there? Okay. The first thing you heard was OSHA was called in because it was an employee accident, an employee death. Now, OSHA cannot shut down a facility, so they may fine you, but the board, who the CDC implements all the guidelines, they can have effects on our license, different things like that. Let me go through a couple more of these if I can.
Howard, while you're reading that, can I jump in on something that's come up? You know, I think many of our offices have been very disappointed today because we were planning to bring on some of our hygiene team potentially on the 18th or thereafter. And many of us are having to change schedules because we tentatively thought that was going to happen. So this morning, the MDS did share with myself and other district leaders this question and some information coming from the MDS. The question is, where does hygiene fit into the governor's phased reopening? Will dental hygienists go back to work on Monday, May 18th? The answer obviously is no, but the answer that they're giving us is this. On Monday, we would expect the governor to announce further guidance. We do not know yet when phase 1 will begin. He may say today or tomorrow or a week from now. However, regarding the hygiene program or our hygienists, it says it depends. Some type of care performed by dental hygienists may be anticipated for patients with underlying health conditions. Absolutely. So just like emergent care or emergency care potentially for doctors, I believe that the MDS is thinking on the lines that there will be some initial hygiene initiated, and this will be up, their further note here after that is this will be up to the clinical judgment of the supervising dentist in that facility. So although that we may not have the routine prophylaxis type of care right away, I know and I do believe that there will be a need for some hygiene care early on in this phase 1 whenever that will start. So that has come down from the MDS, not from me, but further guidance certainly will come.
No, I full well echo that because we have some of our patients who are actually being harmed by not having their recare exams and trophies being done. Those that have underlying conditions. In fact, I feel as though the regular recare should be done for the diabetics. That is almost an emergent type of a situation. Otherwise, we're going to increase our healthcare demands and costs and things like that. So again, I'm in agreement with what the Dental Society says there and would echo that. And there may be other underlying conditions also that should have the implementation and the skills of the hygiene person doing that treatment.
Thank you.
Howard, I'm being asked some questions. I know that you travel out in the area, various states in New England, and people are wondering about this state comparing with other states in our area, how things are being handled. Any thoughts you have on that?
How many
Yeah,
states are currently open for elective? Do we
yeah.
know?
Well, New Hampshire is. I know that. I believe that Maine is, and possibly New Hampshire.
The
Um,
notes I had is that 39 states currently are open for elective dental care
yeah,
as of
yeah, and
yesterday.
they're
I had
quite.
heard the same thing. Does it relate to where the state is in terms of cases and how much the curve is flattened? I think one of the issues here is each state kind of instituted a lot of the stay-at-home orders at different times. So is it just that everyone is at different places within their response to this, or are we just slow? I mean, what do you think?
Yeah, I wish I knew the answer to that. I mean, I hate to be cynical and say it's political, but I think in some ways it may very well be. But it's the advisors to the state that obviously we know that the Dental Society has met with a reopening committee, and that committee is comprised of a number of individuals. I don't know which representatives are on there and what their skill levels are, what their educational levels are, and I think that's what's more dependent on anything is what input they have to give the governing agencies the guidance on when certain things should and shouldn't open. I was pretty disappointed. I thought that, like you all, that dentistry should be one of the areas that should be opened up, primarily because you all in dentistry are medical professionals, and that should be emphasized more than anything else. I maintain that there's no one that can do what a dentist can do. When you think about it, if I showed up at the ER with a broken second molar, what are they going to do? They're going to say, go back to your dentist. If I need an extraction, most likely, unless they have an oral surgeon on staff, they're going to say, go to your dentist. That's the outpatient. That's what we do. We do it well. Um, I know that the Dental Society is advocating to the utmost for the membership. Again, we can appreciate that. We can also be disappointed with the result. But I think Dr. Mariano was correct in that there is some leeway in the wording and the interpretation, and that many of our patients, not the preponderance, but many of our patients would qualify under that definition to be seen in our office. And I think we, under great guidance, and I'll be more than happy to help with any of the documentational aspects, the inspection aspects, the evaluation of the mass aspects, anything like that, to practice safely and treat our patients at the highest quality level, which is what we've done and what we'll continue to do.
Okay, I think we've gone now over 2 hours. If I know a number of us are, we're getting worn out. Great
Yeah.
information, and I know we certainly started this program saying that by the end of it, we want to be a little bit more comfortable about going to the office. I don't know if we've achieved that, but I know what we did do is we all know now that we're in the same situation, the same boat. We all have the same questions. And I think that there's a lot of areas, a lot of guidelines and interpretations that are going to be needed moving forward. I think Monday will be a big day when we find out when the supposedly phase 1 starts. Is there any closing thoughts, Howard, that you would like to make based on where we've gone for over 2 hours?
Yeah, I'd love to make a comment that I've been involved with the Valley District for years and years and years, and some of the finest practitioners I know practice in the Valley, and I'm really fortunate to be looked upon as a resource, and very happy to know many of you on this call, and hope to meet everyone on the call so that we can all grow together. and try to provide the best information. And as I say, move forward into the 2020s and beyond. And I really appreciate the opportunity that I've been given to share some of the information that I have. I'm going to share one more thing with you, and that's this little picture here. Comes from a little website. I'm going to show you the website. I think you'd be interested in it. The website is called Haven Healthcare. And Haven Healthcare, anybody ever hear of Haven Healthcare? I want to share it with you because there are lots of things going on in healthcare, even as we speak and even as we're on the sideline. This is Time for Better. This is a consortium of 3 companies trying to revamp the way healthcare is delivered. And they're kind of tiny companies. I'm going to show you the names right here so that you'll see right over here. Amazon, you might have heard of them, Berkshire Hathaway, and JP Morgan Chase. Amazing what they're doing. The head of it is this gentleman right here, Atul Gawande. I bring to your attention his name. He headed up the response to the marathon bombing here in Boston. Okay, and he's an ER physician. He's the chairman of this, the CEO, and really interesting. He was asked by the World Health Organization to develop what they call pre-surgical checklists for use in third world countries to minimize post-surgical infection rates. And he said, that's a wonderful idea, except I do not know how to develop a checklist. So he wrote a book, and I'll encourage anybody to get it. It's called the Checklist Manifesto. It helps us to organize things. It's what I use. So again, I think it's fascinating to look at some things like that. I appreciate everyone for being here. I appreciate the time, the effort that you're doing, and I'll be more than happy to visit anyone's office, give constructive suggestions, because I think that that's the way to move forward constructively. And I know that within a very short time, we'll be back to doing elective dentistry, but in elective dentistry in the safest possible manner. In other words, with the enhanced protective equipment that I've mentioned earlier. Anyone has any questions, please reach out. Love presenting to you. It's great having the questions. Thank you very much.
Thank you,
Awesome.
Howard. I appreciate it. Ben and Mike, thank you both. You want to say any final words?
No, I just wanted to just say one thing. Thanks to Howard. Also, again, if anyone wants to look back on this for anything in particular that you might have missed, or if you have anyone who in your practice that wanted to come on that could not, again, probably tomorrow, if you just go to YouTube and search for Valley District Dental Society, our channel should come up on there. There'll be 2 videos in there. One will be the town hall meeting, and the second will be this meeting that I'm going to try to upload this evening. So look for that. We're also going to put an email blast out to everyone whom we have an email for with those 2 links that you'll be able to just click it within the email. So look out for that, and tell your friends if they want to get some of the information.
Thank you, everybody. Finally, a final thought. In my tenure here as chair and president, I believe that, especially in this time that we're in, that the Mass Dental Society and what I will call organized dentistry has really showed how much they really can do to help us as clinicians and in our own private small businesses. So they're in a very tough spot. You know, they're dealing with a political situation that is slow to happen in the state of Massachusetts, but they are doing their best. And I've been, along with my board, have been on the inside of what's going on at Mass Dental Society. And I can tell you they're earning their keep, and whatever dues we pay to them, I think is really worthwhile. So I want to thank them. I want to thank Teresa and everyone who was involved in this. Finally, we will be having our spring meeting. It will be virtual. It will be in this format. It is going to be on Thursday evening, May 28th. You'll be getting further details, and it'll be my final meeting as president. I will I will review all of the things that we have done successfully and not over my 2-year term. And we look forward to our new co-chair, our chair-elect, Dr. Marty Wall, who will be becoming president and chair, and look forward to a great 2-year tenure for him and his group. And I certainly will support him during that time. So thank you very much, everybody. Have a wonderful evening, and let's see what happens on Monday. We'll all be up and we'll be listening. And as I have been doing, we will be sending out periodic emails to our members on what we know. And my phone line is always open. Members of the board, please reach out to me if we can help. Thank you very much. Have a great evening.